So we'll move on to the next part of the evening, which is the unique challenges of ongoing care and responsibilities in residential aged care. And it's a pleasure to introduce, we have almost a panel on this session alone. So Dr. Michael Tresillian is going to go first. He's the Program Director at the Royal Brisbane and Women's Hospital. So he's a general physician at RBWH. He looks after the non-ID component of the HITH service. He's also Program Director of Clinical Excellence Queensland's Healthcare Improvement Fellowship. He has a strong interest in new ways of thinking and in safety and quality improvement. Following on from him will be Sam Tapp. Sam's the CNC at HITH RBWH. Sam began the HITH journey at MARTA in 2001 and commenced acute care IV antibiotics at aged care facilities in 2008 as part of Hospital in the Home Nursing Service, now known as RADAR. Sam has been the CNC at RBWH since 2015, advocating for all things HITH, promoting new opportunities and challenging the boundaries. Sam liaises with HITH colleagues across Queensland and beyond, trying to transfer patients closer to home, and is a committed participant in the Queensland statewide meeting group. And Sam will be followed on by Alexandra Pitiris, who is a pharmacist at the RBWH, and Sam will lead on from there. So I'll hand to Michael at this point as the slides come up, I think. There we go. All yours, Michael.
Beauty. Can people see the slides properly there? Great. Well, thank you very much, and thanks everyone for this opportunity. So, yeah, I guess at Royal Brisbane, it's a generalised HITH philosophy is that really where you live shouldn't affect your access to care with the hospital in the home. And our service, I'm sure you'll have similar experiences of sort of turned up in all sorts of places to deliver care to people, obviously in people's homes. We've chased people around workplaces. We've gone and visited all sorts of hotels. Caravan parks are pretty common, and aged care facilities are another area that provide us with some challenges, even though they may seem like they're reasonably simple places to attend, particularly since they have some similar structural similarities to hospitals. But obviously the goals of what we do are to reduce inpatient length of stay, particularly for the elderly patients. We're trying more, particularly since COVID, to avoid admission in the first place. And we have obviously our community palliative care service, which we've been trying to link in with, which involves climbing some mountains around funding models. And we have a sort of radar collaborative now as well that is rolling out in Queensland Health, which puts a geriatric service that has a bit of an outreach capability, and they develop relationships and go into nursing homes with the registrars. They can get medical staff into the nursing homes and help liaise around pre-hospital admission and organise care that might be able to be delivered in the nursing home versus admission to hospital. And they provide advocacy along that whole route, whichever way they go. So we've been working with them, and that's sort of opened some new doors and opportunities, particularly in the last 18 months. And as you'll all know, with COVID-19, there's been a stronger drive to try and protect patients in aged care facilities and minimise exposure to hospitals. So that's opened some opportunities for innovation. I guess thirdly, we value the sort of quality of life for all patients, but for our RACF residents in particular, and you know, coming into at least our hospital, it's a large metropolitan hospital. It's a big task for residents in aged care facilities. They need to, I guess, get prepped on the nursing home end and then have an ambulance transfer into a hospital. They may wait in a transit lounge for a period of time, see their clinician that they need to, and then spend more time in the transit lounge and go home. And again, COVID kind of opened the door for us to try and minimise exposure there and provide less acute care substitution on HITH and moving to the day therapy unit kind of space, really looking at quality of life. And we've tried to stick with that going on, even though I guess nursing homes have opened up, and because it's just the right thing to do. A lot of our aged care residents really enjoyed not having to come in to the hospital. It can be quite a disruptive experience for them. But at the same time, we need to be aware that for some people, they very much enjoy this experience, and we have some patients who really like the social outing, so they still have the opportunity to come in the hospital. The type of common interventions that we're doing in aged care facilities, I'll go through them. One thing we try not to do is duplicate usual services. So we have a large allied health component to our service, but a lot of that can be delivered by community-based allied health services that generally service aged care facilities. So we do try not to duplicate those and make sure that the best services, the most suitable service is doing what they need to do. But common things are intravenous fluids for a variety of reasons. That may be a pre-hospital or post acute care type setting. We still do a lot of warfarin bridging and stabilization. We wonder whether the NOACs might reduce our warfarin bridging needs, but that doesn't seem to have shifted much at all. And that may be due to the fact that a lot of the patients we take for warfarin bridging are not suitable for the DOACs and or are more complex. So warfarin bridging is quite useful. We tend to take that whole role over from the nursing home and go out to the homes, measure INRs, give Clexane, monitor factor 10 if indicated, and dose accordingly. But that does create some issues we'll talk about later on in the talk. Some of the benefits of that are, our pathology labs that might know these patients won't take patients who are not into a stable INR range. And that gets difficult when it comes to weekend discharges as well, where there's nobody who can come out to the home and take the INR and monitor those levels and give dosing advice. So we sort of fill some community gaps and look after some of the more complex patients, which we're well equipped to do. Blood transfusions is something that we've been doing for a little while now, and they can be either PRN or regulars. We have some patients in nursing homes who require regular blood transfusions. And I guess whilst they used to come into our hematology departments or day therapy units, those who wish to receive that in a nursing home are doing so quite safely. And obviously, as I mentioned before, saves a lot of imposition on them having to come in and out. It's generally a whole day experience getting into our hospital. Alongside that, we've started looking into the iron infusion space as well, partly because our day therapy units are filling up with all sorts of other monoclonal antibodies, etc. And we can give these safely in the community, particularly in nursing homes. So again, some just PRN patients who have low iron and it's indicated to give. Others are regular attendees, and we have some on the service who are getting frequent infusions for this purpose, and they generally belong to our hematology department. IV furosemide is one thing that we've been continuing to explore. It's one of the old chestnuts from HITH. And we tried to be not just reduce length of admission, so earlier discharge back into the community with HITH for patients with heart failure, but we've also tried to intervene in the decompensation state. So with our radar service, there's a frequent request. I guess there's a lot of patients who are struggling to control their fluid overload with oral furosemide and other diuretics as well, other oral options such as bumetanide, sorry. And generally they tend to come to hospital in a reasonably decompensated state when those means have been exhausted. So we've started to look into options where we can go out to a patient who's proven difficult to manage from a diuresis point of view and admit directly to the service. So preventing admissions in the first place. And that's really become quite possible due to our radar service, and our cardiology service has been quite curious to explore that as well. So they have some patients in aged care facilities who are brittle heart failure patients, and we've linked in with them through their outpatient clinics to go out and try and assess these. Sometimes that involves a medical admission. They are typically challenging patients with a lot of comorbidities, and we've exploited the ability of us to occasionally send a medical officer out with the radar doctor and do a review in the home, get familiar with the patient, and then admit directly to the service. That's been an interesting little change, and most of these have probably been nudged along these newer approaches due to COVID, and we see value in them and would like to continue those ongoing. And monoclonals is another area we were incidentally looking at, given some of the monoclonals in the community, particularly for infliximab and some of the MS drugs, and there's some data overseas that these are reasonably safe to give, or quite safe actually for some of them, including infliximab, in the community space. And our nursing staff are well trained to manage reactions around blood transfusions. So we felt it would be reasonable to look into the space in HITH. And during COVID last year, we had a nursing home patient who is on a regular infliximab infusion. So they were facing 14 days of quarantine every time they came in, 6 to 8 weekly basis for their infliximab. So we were able to negotiate with the nursing home to go out and deliver that in the nursing home. Now, acknowledging there's not a lot of people in aged care facilities who are on monoclonals, but you know, this is one pathway that's providing particularly good quality of life for a patient who is in a nursing home, really due to physical needs rather than cognitive. We do a fair bit of antibiotics, and whilst I don't manage that space, obviously being in a nursing home doesn't impact on that at all. One of the other areas we look at is complex wound care, and a lot of nursing homes, they have some skill sets to look after wounds. So again, we try not to duplicate services, but any complex wounds where the aged care facilities aren't comfortable with perhaps different types of dressings, we can go out and provide a mentoring model. And we are particularly active in the negative pressure wound therapy space that is a bit more specialist. So that's kind of filling a community gap there, but is valued and of good use. Another pathway that we don't use at Royal Brisbane Hospital, but within the Metro North HITH service, other hospitals are using it, is a delirium pathway. Normally in nursing homes, we, at least in the general medical department I work in, we will discharge them back when suitable to the nursing home with, and they support the delirium from their end with our allied health services. But other hospitals are trialling that, and that may be complex delirium cases, or they may be providing additional allied health input. The clinical challenges, you know, are probably due to structural differences between the way nursing or aged care facilities work versus healthcare. We are quite cognizant of the fact that when we're looking after nursing home patients, there's dual management from a medical and nursing point of view. So we have to be quite respectful of that, and that there are primary caregivers and we are an adjunct service. And I think that's one of the ingredients for a good collaborative service. We certainly don't want to be seen as the experts coming in and sort of dictating how things should be done. So we work on building collaborative relationships with the doctors who look after the residents and with the nursing staff within the nursing homes. And that's certainly aided by our radar service, who have spent a lot of time building good relationships between the acute facilities and the nursing homes within their catchment. Variable dose medications are probably one of the biggest sticking points, and Alex might talk to this near the end. We have had some medication incidents, particularly around dose duplication, and the issue is that nursing homes have their own medication charts that they dispense from, and then we have our own medication charts. So we've seen double doses of warfarin given by accident when our nursing staff have given one, and then later on in the day at the facility, the nurse looking after the resident has also given warfarin from the nursing home chart. And obviously we can't easily make changes to that to that nursing home chart from a hospital point of view, and it's generally up to the GP. The addition of PRN medications can also be challenging, again, for the same reasons. that we operate from different prescribing charts. And I guess one of the things is we may go out to a home at 10 o'clock in the morning to do a warfarin dose and then dose at that time. And that adds, I guess, areas for failure when the warfarin can be given by a nurse on a different shift later on in the evening, as they traditionally tend to do. Nursing home rostering also creates issues, obviously, with handover and shift changes and communication. There's a large number of residents in facilities and the ratio for each nurse is a lot higher than acute care, and that comes with it some risks. Another thing is the various formats of documentation. There's the electronic medical records that some of the facilities have. Some operate on paper. We still operate on a hybrid paper EMR system at the Royal. And then some of the facilities also have automated dispensing. So they're just all little checkpoints that we have to be cognizant of, and that can get in the way. The next thing is communication with the Trinity GP and community pharmacy. It just adds another layer of complexity to the whole process. And changing the medication is no longer as simple as asking the HITH nurse to make a change. You have to contact community pharmacies. We try and keep the GPs informed as best we can. Some of them don't work 5 days a week. So you sort of have to always remain a little bit agile and on your feet. I'll just pass over to Sam Tapp, who's CNC.
Thanks, Michael. I thought I'd just explain that Michael and I are both based at the Royal Brisbane, and that we're one of 4 major hospitals within the Metro North area, and we refer all into the Metro North team that deliver the care. So on any given day, they're seeing up between about 60 to 70 clients, and some of those will be visited twice a day. And out of those 70 odd, about between 3 and 5 per day clients will be from aged care facilities. So it's not a great number, but they do take up some of the time. And that number, 8,700, is how many aged care beds there are within the Metro North region. And that's a huge number. So, I mean, most of the participants online would be well aware of the HITH assessment criteria, exclusion criteria. Those things all apply in the same vein, but assessing patients that live in aged care is another added complexity. You've got, making sure that the appropriate plan of care is the pathway ahead, and then you're needing to engage with the patient and or their family member, making sure that your aged care facility staff have the skill set or the capacity to receive the client back to that campus, remembering that we're actually asking them to take more time and care and attention to that resident. So we can't really do anything without the collegiate relationships, and Michael's spoken about those we have with radar and palliative care. The other thing to be mindful of is the client's ability within that space. Have they got the cognitive ability to manage having either an IV access or a PICC line? And those are things that we're really relying on, how they've been demonstrating behaviours on the ward-based, with their ward-based cares. If they've been struggling with dealing with an IV site, then is this the right way to go about treatment at home? Something that should be determined before is the threshold for return to hospital care. And that's, I think we talk about that with any client, but in this case, it's a thing to very much consider, taking the patient back to hospital out of their own home environment. And in the hospital avoidance space, we're going through all of those same assessment as to whether or not this is the correct care at the correct time. One thing of note is some clients may not have had the regime that we're considering, and proof of dose is one of those things that is a sticking point in with a lot of services, and we seek counsel from our pharmacology consultant as to the threshold of risk for things like IV furosemide if clients haven't had that before. You know, the logistics and challenges, as I said, it's around communication, and it's the key. And it's the next slide, Michael, please. Thank you. Communication is at the crux of most medication incidents. Riskman data will tell us all that communication is the key factor. And in this space, you're adding almost a triple layer of communication, because you're talking to the family member, the staff member at the unit, and making sure that everybody's on board with the plan of care. The logistics of actually visiting these campuses is time consuming for the staff. They're large campuses. They've got entry and registration processes were lengthy, especially during COVID. They had to sign in, talking about PPE, donning and doffing, finding a staff member, then finding the client. And then at the end of the visit, you have to document into their electronic records. So it isn't just simply, even if it's just a warfarin or a clexane or ceftriaxone, you still really need to allocate about an hour to do that visit and provide that appropriate care. We need to respect that, you know, the aged care facility has they're a business, we're a guest on their campus, and we need to respect their legislative sort of constraints as well. Things like flu injections have to be had by all staff members entering onto an aged care campus at the, as of the 1st of May, it's mandated. So it's all being aware of all of those nuances. And at the end of the HITH episode of care, we almost certainly try and hand over back to the GP if we haven't already engaged with them throughout the course of the treatment. That's an important step that, you know, is often missed, I think, sometimes. We very much value that relationship. Medications, I mean, hopefully Alex is having some internet struggles, but hopefully she can speak more specifically to the pharmacy. But, you know, most facilities have electronic dispensing systems or packaged medications. As Michael said, titrating diuretics and anticoagulation is a difficulty. Are we on the next slide? Sorry, Michael. IV antibiotics, interestingly, are perhaps one of the most easiest things to manage because they're a defined medication. We know exactly what date they're going to finish. If the patient remains stable and well, there's not much that can go wrong unless the patient, we've assessed them, will misassess their ability to manage an IV line. Liaising with the community pharmacy is important. So I'll hand over to Alex if she's able to be online. She's been messaging me that she's got internet issues.
I think we can see you there. Can you hear us, Alex? Pop yourself off. There we are. Go for it.
Thanks, Sam.
Next slide, Michael. I'd just like to add, just before we go on, despite all the complex issues and risks, you know, these clients are actually enjoying the opportunity to have these regular episodes of care, and I won't speak to them, everybody can read them, but you know, that's just a smattering of the regular clients, and obviously also the acute clients that we see. Thanks, Alex. Thank you. So Alex has been with HITH for about a year now. She managed to get into a role and get into Brisbane just before COVID gloomed over us all. She prior to that was a community pharmacist for 5 years and is now really enjoying the multidisciplinary approach to pharmacy and involved in the patient's care. Thanks, Alex.
Thanks, Sam. Yeah, so HITH in general for me is still kind of fresh, but I'm yeah, really enjoy working with the team, and I think in the nursing home area of things, I think there's still a long way to go, especially from a pharmacy perspective. As Sam and Michael both touched on, there's a lot of logistical issues that can just sort of be very time consuming, and there's always that risk of, you know, medication misadventure, whether it's, you know, obviously most of the time it's unintentional, but I think we've definitely got a long way to go. So in general, what we see in HITH pharmacy is, you know, there has to be that sort of chain of communication from the hospital pharmacist, generally goes straight to the nursing home / community pharmacy that would supply the nursing home with the regular medications for the patients. We usually will get either a phone call handover from the pharmacist at the hospital, or, you know, when the patient comes onto HITH, we do our own sort of digging around, and we find we get the interim medication administration records that the hospital pharmacist will do up when they do their discharge summary for the patient. So that's essentially, it's a short inpatient medication chart that the nursing home can use in place of their regular GP chart, and they generally will provide, you know, 5 to 14 days worth of the medications to ensure that we get that smooth transition of care from the hospital back to the nursing home. Because oftentimes, you know, medications are changed or added in or removed, and being that the packing pharmacy generally has to make changes to a blister pack or a sachet roll, it can be quite time consuming, and it doesn't always happen straight away. So that's where that short supply will come in really handy. We will usually follow up as soon as the patient comes on to HITH. We'd follow up with the nursing home staff and the packing pharmacy to make sure that everybody's got the same list of medications, everyone's on the same page, because things can definitely get missed. And as Michael mentioned earlier, changing doses of medications during the HITH admission can be really tricky, especially PRN things, or things like titrating your furosemide doses for your heart failure patients, because it involves a lot of extra steps in terms of getting them recharted and getting medications supplied, that sort of thing. We go to the next slide, please. Thank you. So in our process of reconciling medications with the nursing home, it generally just will happen with the nursing home staff, because in most cases we're not always able to speak directly to the patient or a family member. You know, whether it be the patient doesn't have, they're not cognitively able to, or if you know, we're treating them for something like Delirium Pathway, where, you know, it's not always appropriate to speak to the patient. We have a small supply of impressed medications at North Lakes, which our nurses will use to take out for treatment. Obviously, it's not a full-fledged pharmacy, so this makes things a little bit tricky in terms of starting new medications or changing, increasing or decreasing doses of medications that we don't have available to us. So they do have, you know, your standard IV antibiotics, enoxaparin injections. We also have the antibiotic infuser pumps, which they take out each day. We keep them at North Lakes in our fridges, and the nurses will take them out each day for connecting. Like I said, we don't have a pharmacy, so if we need other medications supplied, we have to coordinate that with the packing pharmacy, because some nursing home pharmacies will continue with the packed medicines. Some will choose to withhold the packed medicines, and then it's up to us to ensure that the supply is maintained. It just really depends on the pharmacy and the nursing home, and I think not having like a set, I don't believe there's any kind of set guideline about, you know, what, you know, whether the medication dose administration aids should continue or should be withheld. It kind of, you sort of just have to gauge each facility. So in most cases, the dose administration aid will continue, but if there's significant changes to any of the medications, that's where your interim or your IMAR, interim signing chart, will come in, and if they have to make changes, the pharmacy usually is pretty quick at changing them, getting them delivered to the nursing home. But if it's not able to be done within a timely manner, then that's where that interim supply of medications will come in. And some pharmacies as well actually prefer for the nursing home GP to rechart anything that's been changed in hospital, which can become a bit tricky as well, because a lot of, as we know, our patients are still inpatients, and so technically the GP, a lot of GPs prefer not to step back in until the HITH admission is completed. So then we get, but then you get some GPs who are really proactive, and when their patients come out of hospital, they want to see them straight away, and they may then go ahead and rechart everything as per our IMR, or in some cases they may also change things back if things were changed in hospital that they want to change back, and we don't always get notified about that, and so then our list doesn't match up with their chart, and that's when things can get a little bit muddy. So we try to keep in regular contact with the nursing staff, just to ensure that, when does the GP do their rounds? Will they be reviewing this patient? The IMARs themselves are only a 6-day chart. So, if the patient's going to be on long term or for, a few weeks or more, if the GP is not going to be involved in recharting because they want to keep out of it until HITH is finished, then we have to keep sending interim medication charts, which is the time-consuming process. We usually, and if we don't have a doctor on site at North Lakes, which in the case of the Royal Brisbane we don't, it would be a matter of, we send off the IMAR, get them to sign it, send it back, we send it to the nursing home. So there's a lot of extra steps involved, which makes it a little bit tricky to manage. And then I believe Michael touched on the warfarin issue a little bit earlier about, doubling up on dosing. Can be a bit concerning if, the nursing home is not using the IMAR for any reason, whether it be, they prefer for their GP to rechart. And if something has to be withheld or added in or changed, then it can become a little bit, hard to coordinate everything with so many different people involved in the pathway. But I think, there's definitely a long way, a lot of work to be done, I think, from a pharmacy perspective, because a lot of the GPs in nursing homes don't see their patients every day, or sometimes it's only once a week or once or twice a week, and so the medications may not be reviewed for a week at a time or whatever the case is, and and then changing something as simple as changing a frusemide dose involves us doing up a completely new medication list and sending it out and ensuring that they have the stock, which sometimes they don't. And if it's a non-list of approved medicines or non-LAM medication, then we have to source it from an outside pharmacy. If it's, that may involve having the patient's family member go and pick up the medication, whereas we would normally supply it through the hospital. And again, that's extra steps involved because we don't have our own pharmacy, so we have to have our AINs collect the stock from the Royal Brisbane Pharmacy, for example, and deliver it to the nursing home, which could be, on the other side of North Brisbane.
I think you have given us a great illustration. The logistics involved in the pharmaceutical, just the sheer stocking and management side is really challenging in that setting. So, Michael and Sam and Alex, we'll come back to you at the end because there are a number of questions there. Thanks to those who have submitted them. There's some excellent questions there, which I'm going to cover